Hello, everybody, and welcome back to the Lube Tube. My name is Jeanette, and this is my co-host, Brittany.
Hey, hey, hey.
All right, guys, this episode is going to be all about the thyroid, basically our body's metabolic control center. And I think that this episode is going to be really important because I think this is one of the most underdiagnosed things. I know when I was doing primary care, almost every single woman came to me and was like, can you please check my thyroid? And I would, obviously only diagnose that in a very few people, because since I started doing thyroid a little bit more intricately, I guess the word is, I've noticed that I'm finding more thyroid disorders, because at that point I was only checking one lab value. So we're going to be talking about all different kinds of lab values and the different types of thyroid conditions, hyper versus hypo, and just kind of go from there as far as how we can basically diagnose and treat and try to make this a little bit better for our patients. Right?
Yes, and before we go on, can we just address the obvious right now?
Oh, yes. Yes. It's rodeo season in San Antonio.
It is rodeo. We're both wearing bolos, and I think we both have stories about our bolos. So you can go first, Jeanette.
Okay, so for my birthday this last year, Brittany and a bunch of our lady friends all went to a place in Texas called Round Top. And Round Top is a really cool place that basically it's a lot of antiquing and little shops and cute little cafes and bars. And we went into this really cute shop where this lady was making these all by hand. And one of our really good friends, her name is Lauren, she bought me this for my birthday. And it is one of my favorite gifts. And it says Texas on it. And it says all the little places in Texas. And so Brittany, when we first got on here to start recording, had hers on. So I was like, I want to wear mine. So I went and got mine. And yours?
Mine, first of all, is so antique, but not from Round Top. One of my other friend, Lauren, her grandmother I met a few times, and she was just the most wonderful, vivacious woman. And sweet Grandma Alice actually passed away recently. And we went to Seattle for her celebration of life. And part of the time when we were there, we were in her house. We were kind of going through things, and they said, hey, if you want to go through and see if there's anything you want. And I ran into this bolo, and this is legit. Okay, this is sterling silver for sure. This is 100% leather. And I know Grandma Alice is looking down. I'm like, you're such.
Cheers to Grandma Alice.
I know. Cheers to Grandma Alice. She was the best. Yes. So, and great style, right?
Yes. And I might even add my hat because it's rodeo.
Oh, see, that's cute. I don't have mine. I just got a new hat yesterday, and it was a labor of love, to say the least. So.
I know, because I remember when your mom was like, hey, you need to add this, you need to add this, you need to add this on that first.
No, that my mom took it to the rodeo and had a few drinks and decorated my entire hat. Let's not forget that, Roxanne.
Oh, yes.
Anyway.
And that's a huge style right now, right? You get your hat and then you can add all kinds of little designs to it. You can basically add feathers and little charms and leather, and they come out so cute. So cute.
Yeah.
Okay. So happy rodeo season.
Happy rodeo, y'all.
All right. So let's briefly explain the importance of the actual thyroid itself. The thyroid is a gland that sits in your neck, right? And it gets stimulation from the brain, and then it turns around and sends out different hormones out through the body, right? And these basically different hormones then control our whole metabolic system. And we have these receptor sites all over our body. So certain things like fatigue or hair loss or hair growth or dry skin, they can all be a sign of the thyroid not working as well as it should. So we're going to talk about the different things, like whether the thyroid is working fast or it's working slow, or if it's working what we call euthyroid, which means perfectly normal. And we're going to kind of talk about how each of these plays a role in how we feel. Sound good?
Sounds great.
All right. So basically, the thyroid is it's a huge role in metabolism. In fact, that most people, if they have normal everything else. So say you come in to see me and you have no anemia, your thyroid or your kidneys are working fine, your liver is working fine, all your hormones are okay. I'm now concerned, okay, if you're gaining weight and you feel fatigued, or maybe you have constipation, or maybe you're not sleeping good, or you have dry skin, brittle hair, now I need to know, is your thyroid working okay, right? And so the thyroid, when we check blood work, originally, in most primary cares, it's only being checked is the thyroid stimulating hormone. Okay. The thyroid stimulating hormone, or TSH, comes from the brain in a little gland that sits here in our brain. And then it goes down and it stimulates the thyroid, which sits here in our neck, to basically kick out different hormones, specifically the free T3 and the free T4. Okay. These hormones then come out and then they go to these receptor sites that are literally all over our body. And they are what maintain our metabolic system. Okay. So when we check the thyroid, I feel it's important not to just check the TSH, right? I want to check also the ones that come out, because if we're just checking the TSH, there's so much here that could be going on, right? Is the T3 coming out appropriately? Maybe. Is the T4 coming out appropriately? Maybe. But the only way we're going to know is if we check all the hormones that come out of the thyroid, not just the stimulating one from the brain.
Right. And I think that is a lot of times when we get our ladies in and we tell them we're going to check your thyroid. Oh, my primary is checking that, which is great. I want somebody to follow it. But when you really start talking to them, they are focusing strictly on TSH, which I mean, there's lots of controversial things in medicine. And I think truly one of them is what are you measuring when you're looking at a thyroid? So,
right. And I'll be honest with you, most primary care, when probably my patient goes back to see them and I've already kind of checked everything else, they probably don't agree with me adding on a medication if I do, just because the TSH is within normal limits. So this can be a little hairy, right? There's obviously, like Brittany said, different ideas on how to treat, when to treat, and if you should treat the thyroid. But I very much go off of how the patient is feeling, and then also go off of what I'm seeing on that full lab profile, right?
Yeah.
So
got it.
Let's first talk about the thyroid not functioning appropriately, right? So this is called hypothyroid. In medicine, when something is hypo, it means it's not working as well as it should. And when something is working hyper, it means it's working overboard, right? So in this situation, hypothyroid is where the thyroid is a little sluggish, okay? And there's different reasons why this can happen. But the main one and the common cause is that the thyroid working slowly is something called Hashimoto's thyroiditis. Okay. Hashimoto's is actually an autoimmune disease, and where the autoimmune, or your body itself, is fighting itself and fighting the thyroid, and it's causing a state of inflammation throughout the entire body. And in these patients, what they'll commonly complain of is fatigue, brittle hair, dry skin, and a lot of times they'll have weight gain, where these ladies could be working out and doing everything like we've talked about in our other episodes, eating right, working out, taking their supplements, and still they're having this pesky weight gain that's just driving them nuts, right? They also a lot of times will complain of being cold all the time when other people are hot. And so we call that in medicine cold intolerance, right? So in this situation, I think it's important that we actually not just check that TSH, but also check some other things like the free T3. Okay, so that is another hormone that comes out of the thyroid. And then the free T4 is another one. There is a main antibody that we also check called a thyroid antibody, or a thyroid peroxidase antibody, TPO, right? And this antibody in Hashimoto's, it's going to be elevated, right? Because your body is literally attacking your thyroid. And so what you'll find is that maybe the TSH, the free T3 and free T4 are all within normal range on the lab values. But then you'll have this antibody that is like through the roof, right? And when that's through the roof, I'm telling you, your body is inflamed, right? And you might have normal labs, which is great. I'm glad they're normal, but that doesn't mean they're going to stay normal, right? And in this situation, I really focus on the free T3, because the way the thyroid works is the TSH comes down, it hits the thyroid itself, and then kicks out free T4 and free T3. And in most cases, the free T4 is the most amount that comes out. It's like 80 to 20% between the free T4 and the free T3. So then what happens is the free T4 then has to change to free T3. And in thyroid, when the thyroid antibodies are high, there's actually an antibody or an inflammation that doesn't allow the free T4 to change to free T3. And the problem with that is most of the receptors for our thyroid are free T3 receptors, right? And so if the free T3 is not being made accordingly, like it should from the thyroid, and then the free T4 is not changing to free T3 like it should, then we're not getting enough free T3 in our body, which then we're going to have all of these symptoms. So on this lab value, I really focus on, hey, does she have thyroid peroxidase antibodies? B, how does she feel? And C, what is her free T3 value, right? Because it could be an optimal range, but does that mean it's optimal for that patient?
Yeah. And I think something also to note is that the symptoms that you kind of just went through, they can certainly look exactly like somebody that is going through perimenopause. That is getting,
I know.
And so I think that's where there's this blurred line is what are we treating? Right.
Right.
And so that's why it's imperative that we do get not only thyroid panels, but also we need to check all your hormones.
Right. And I always stress that, I have a patient that will come in and they'll be like, well, my primary care already drew the blood work. So why do I have to get more blood work? And I get it. Nobody wants to be poked multiple times. Nobody wants to pay for more labs that don't need to be done. But in most settings, unless your PCP is checking a full panel, right? An FSH, a TSH, a free T3, free T4, estradiol, testosterone, all of the labs, you might not be getting the full picture, right? So that's why I always say, hey, if you're going to see your provider, make sure they're running everything, right? Because personally, I just told you when I did primary care, I was only going off the TSH until I learned so much more about the thyroid and really started digging into this in women's health, right? So I think it's really important that you have that conversation with your provider to make sure that all of that is being drawn, right?
Right. Okay. Well, let's move on to how the heck do we treat this, Jeanette?
I know. So this is another... a sticky subject, right? So in most cases, and the one medication that is well known to most people that treat thyroid or maybe have a thyroid issue is Synthroid or levothyroxine, right? That has different names. There's Tyrosint, there's Levoxyl, there's levothyroxine, there's Synthroid. It has all kinds of different names, but it's all the same thing, right? It's all giving the patient T4, right? And so kind of what we talked about is, in the body, the T4 hormone, the body converts it to T3 into the active form. So the problem here is if you don't have enough of that converting enzyme for the T4 to change to T3, you might not get full symptom control, right? And in those situations, that's where I feel like maybe giving a patient free T3, which is going to be in the form of NP thyroid or natural desiccated thyroid. Gosh, there's a lot of different ways to put that. There's a lot of different ones out there, but NP thyroid or armor thyroid is actually giving the free T3 component rather than just focusing on the free T4.
Well, and I remember, how I like to talk about pharmaceuticals. I remember when we would have patients come in and say, "Hey, I think it was CVS. I'm just really calling out all the people. CVS was like, sorry, we will not cover NP thyroid. So all you can get is this." Yep. And then our NP rep came in and said, essentially, that's bullshit. They can do that. They're just trying to push you to not do that. Granted, it was an NP rep telling us, but she was right. It was, you could get it. It just took a little extra effort. And I agree with you. There are certainly more people that I've seen on NP thyroid that have. Actually, I shouldn't say that. There are people that have done well on levothyroxine, but NP thyroid, in my experience, has seemed to work a little bit better.
Right, because with NP thyroid, you're going to get a little of the free T4. It actually has a little bit of that, but it also has mostly free T3. And so I see better control of those symptoms in my ladies, right? I see better when they come back to see me, they're like, oh, they have a little bit more of that spunk about them, more energy, maybe less dry skin. Maybe they're not as constipated, right? Because they're actually getting that free T3 instead of depending on that conversion of levothyroxine to the free T3.
Mm-hmm.
And so moving forward, here's the thing. Do we still follow just that TSH, right? So say I start a patient on NP thyroid, right? Okay, great. Come back and see me in about 6 weeks, get labs drawn right before. And I want you to take that medication and then repeat your blood work 5 hours after you take that NP thyroid. And why do I do this? I do this because that is how long it's going to take the body to take that NP thyroid and use it and get an actual free T3 level that is measurable, right? And that normal level is going to be anywhere from, in these patients, really, I like it anywhere from 3 to sometimes 5, right? To get optimal control of those symptoms. What is this going to do to that TSH? Right? That TSH is now going to be suppressed, or it's going to be really, really low, right? And then you've got primary care physicians freaking out because the TSH is low. Well, the only reason it's low is because it's then sending back this feedback to the brain saying, hey, we got what we needed. I don't need you to stimulate me anymore, right? So quit trying to tell me what to do. I'm getting it from this little pill and you just need to calm down, right? So now the TSH is going to be low, but guess what? The free T3 and free T4 are now optimal. Now they're right where they need to be. They're not crazy high. Your patient's feeling better. So let's not focus on that TSH. So many providers, I feel like, focus on the TSH, me being one of them, right? Prior to my studies in the thyroid. So I do feel like too many times we focus on that TSH being low and then we freak out instead of just, hey, asking the patient, how do you feel though? Like, are you having palpitations, which can happen when your free T3 is too high? Are you feeling a little anxious? Are you not sleeping as well as you normally do? Is your blood pressure higher than it should, right? If all of those are normal and you're feeling great, I'm not worried about that TSH being low, right? Mm-hmm. I don't know if you find that, like when you follow up these patients on your annual labs, when you do your hormones, or maybe every your Q6 weeks labs. And a lot of times after you have started the NP thyroid, or maybe even I've started them on it and then I send them to you for the hormones. I don't know if you find that the TSH is now low, right?
Oh, absolutely. Absolutely.
Yeah.
But, you know, like you said, prior to really like going into thyroid, I was only looking at TSH as well, but it's the education, you know,
it's out there. It's out there. We just got to go look at it.
Yes. Well, and like, so there are like some pros and cons too. I mean, here we are, we're talking about how great NP thyroid is, but like we said previously, levothyroxine can still be helpful.
Sure.
Yeah. I don't want people to think that we're totally shitting on it, because we're not, because there's a lot of people that are on it. We're just explaining why there's other means that can be helpful.
Yeah, absolutely. Because in some patients, they're really good at converting that levothyroxine to free T3.
Exactly.
And if they're really good at converting that, levothyroxine's great, right? But if they're not so great at converting and you give them levothyroxine and their free T3 is still low and they're still symptomatic, maybe there's something else we need to do, right? The downside of NP thyroid, and like you were saying, and the Armour thyroid, is that insurance doesn't feel like patients need it, right? And a lot of times I get notes back that say, this is not on formulary, right? Patients' insurance does not cover this. So then what? Well, then I say, well, either I write a letter of medical necessity, which, let's be real, that doesn't always work. Or we have to use, like we talked about before, like the GoodRx app and get that at a cash pay price. But we're still looking at $75 for a 90-day supply, when if they could get levothyroxine, it's $4, right? Now we're set with patients. Are we going to pay $75? Or are we going to pay $4 for the 90-day supply?
Girl, I'm paying that $4.
Right.
Sorry. I'm paying $4. There's no
patients
question.
would choose that because
right?
I'm sorry, am I going to buy my kids dinner or am I going to pay for my thyroid medicine? I mean, This is real life here, right? And that's what's so frustrating, is getting these insurance companies to understand why we choose this medication in certain patients, right?
Yeah. When your letters of necessity, they should start like this.
Okay.
Dear insurance company.
Okay.
I really hate you.
Oh, okay.
You make my job so hard. And I think I think it's a really good
Maybe
way to
I'll
start.
change my template and add that to it.
Yeah.
Dear insurance company, you suck.
If our letter of necessities were really like what we wanted to say, it would start like
they
that.
would not be appropriate.
Yeah. No. It's so frustrating, but we're willing to do it for our patients. So
absolutely, because I want them to feel better. Because guess what?
Exactly.
Then they come back to me and they feel like crap still. And now they've been taking a medication that's not working for them. That's the point,
Soapbox.
The other option is maybe even sticking with levothyroxine, right? So you're getting that free T4. And then there's another one that we could add on to levothyroxine, and that's called Cytomel or liothyronine, right? Liothyronine is affordable, right? It's not as expensive as doing the NP thyroid. So a lot of times in these patients, if their NP thyroid or Armour thyroid is not working, I'll put them on a small dose of levothyroxine and then add on the liothyronine. The downside of that is it has to be taken a couple times a day, right? Because it has a really short half-life. And half-life, what that means is how long the medication lasts in the system, right? So in these patients, what will happen is they'll have to take a dose and then later on take another dose. And I don't know about you, but I always forget if I have to take a medicine twice a day, I usually forget that evening dose, right? Just saying, just throwing me under the bus.
Yes.
Damn antibiotics.
I know.
So, it really is going to come down to what treatment, if we have questions about this, which one is best for you. And it goes back to that symptoms, right? It goes back to those symptoms. It goes also back to your lab results, right? Not just the TSH. Your provider might get annoyed, right? Because if you go in and say, hey, I want the full thyroid panel, they're going to be like, why? We're just going to go off the TSH. Well, find somebody who will go through the whole thing with you. Check the free T3, check the thyroid antibody, check the free T4, and they might get really annoyed. And if they do, sorry, but you need to know that about your body, right? You need to know what those levels look like, especially if your symptoms are not controlled on the current medication you're taking.
Yes. Something's coming to me that I need to say. There are a lot of people that have a beautiful thyroid for most of their life. Everything is peachy. You've never had a thyroid issue. And then all of a sudden it's just like, bam. And this kind of goes back to when we were talking about in the bone episode was it the bone episode when I was talking about how we're living too long? I don't remember. Yeah. So it's kind of the same thing with the thyroid, right? The thyroid really has it can only last for so long. So I know, I don't know the exact percentage, or I would say it because I love numbers, but I know it's incredibly high for how many people's thyroids just say, I'm done. I need some help.
Done.
Yeah.
I know.
So,
and I think that goes underlooked, right? Yeah. I agree.
Underdiagnosed.
I agree because, is that the word? Underdiagnosed.
Underlooked is cute too.
You're so sweet to me, asshole. Something else that's really important, and we don't usually see this in the United States as much, but other countries that don't have iodine, right? A lot of times an iodine deficiency can lead to a thyroid disorder. Our thyroid loves iodine. So if you have a diet that's really low in iodine, you might be having some thyroid symptoms. So a lot of times I do recommend iodine support, right? And you can get iodine over the counter. You can get iodine in certain nutraceuticals like we talked about in the supplement issue. There's a couple different companies that make some really good iodine support. So I do think that adding iodine on, even if you have a diagnosed condition of hypothyroidism, can be very, very helpful in supporting the thyroid and how it functions. So I think that's another option as far as adding supplementation on, or maybe even treatment. So say your thyroid levels are all great, right? But you still feel kind of sluggish and maybe you are on medication or you're not on medication. Adding on a thyroid support can be very beneficial to patients that are feeling that way.
Definitely. Okay, we've talked a lot about hypo. Why don't we talk about hyper for a minute?
Yeah. So hyperthyroid. these people feel like shit, right? They do.
Yes.
I'm just going to be very blunt. These are the patients that you may have seen maybe like super anxious, excessive sweating. They could even have where they have their eyes are bulging, right? And you might see patients where their eyes are literally bulging out of their face. And that's actually a medical term. I always say this wrong, but I think it's called exophthalmos. I always say it wrong. How do you say it?
I don't.
Okay.
If I can avoid saying something that I don't really know how to say, I'm probably going to avoid it. But I will say the way I get people to understand this typically is I talk about Missy Elliott, because if you remember, so Missy Elliott was like the thing for a while, right? She was killing it. What do you think her best song is?
I don't know.
Work It. I need a glass of water. I could keep going, but I'll stop. So
yeah. Okay, I'll tell a story about that, but keep going.
Okay, so she disappeared. She was like on top of the world, and then she disappeared. Right. And what happened was she got diagnosed with Graves' disease, and had that. I mean, her eyes were. It was a problem for her. Like she felt like she couldn't be out in public. And now, if you look at a picture from Missy Elliott back when she was killing it, I mean, she still kills it when she does things, and now you can still see that her eyes are bulging just a little bit.
Yeah. And this is, there's actually medications out just to treat this specific symptom these days. And there wasn't before. And this is something that sadly, it doesn't go away, right? Even once the Graves is treated, a lot of times this does not stop, right? And what these patients will have is basically it's an overproduction of the thyroid hormones, like the T3 and T4, like we were just talking about. These patients are producing too much of that, right? And when they produce too much of that, it's usually going to end up in symptoms like their heart racing, super anxious, really sweaty, the bulging eyes, like we talked about with Graves' disease. And these patients can also have their periods be way whacked out, right? Because the thyroid actually does play a big role in how we menstruate. So it can actually really throw the period off too. So a lot of times when a patient comes to me and maybe they have a unexplained anxiety, or maybe they're losing weight when they're not really trying to lose weight and they're really having a hard time keeping weight on, I will check that full panel, just like I talked about earlier, where we check the TSH, the free T3, the free T4, and then also the thyroid antibodies. Okay. So how do you diagnose this? So say the patient comes back and the labs show that, hey, they're hyperthyroid, right? This is where I send to endocrinology. I don't really treat hyperthyroid. It's just not something that I feel confident in treating. And this is like endocrinology. This is their bread and butter. So in this situation, a lot of times what they'll order is something called a thyroid uptake scan. Okay. And that's actually where we give you a dye, right? Basically something like that in the IV. And then we focus on the thyroid and we do imaging and we see how much of that dye is taken up in that thyroid. And that test will show us, hey, is it hyperfunctioning or hypofunctioning? And then from there, they'll be able to kind of diagnose and treat that patient. And these, sadly, we have to use different types of medication that can be pretty rough on the body too. There's medications called methimazole. There's a medication called PTU. They actually have to do radioactive iodine to actually shrink the thyroid. And in some cases, they actually have to have a thyroidectomy where they remove the thyroid altogether. And then for the rest of their life, these patients will be on medication to replace the hormone that is no longer being made by the thyroid because it's no longer there. Make sense?
Yeah, that's why it was hard for Missy to come back because she couldn't get it managed. I know it's really difficult.
Do you know what she ended up having done? Do you know if she had surgery?
I don't remember, but I know it literally took her out of the public eye for years. So I don't know.
That's sad.
We need a Missy documentary. I mean, it's probably out there. I just haven't watched it, but
I mean, we have everybody else's documentaries. We need a Missy Elliott
documentary.
Let me go back to the story.
Okay.
So there's a doctor that works in our little area where we work. And she's always playing like ratchet music on her computer.
I love it.
You know who I'm talking about.
Yes.
And it's so funny because she'll have like the other day, the WAP was on. And I was like, in a gynecology office, we might not want WAP playing in the background.
What a bop, though. Honestly, such a bop.
She walked in and she was like, her computer was obviously playing this music. And she's like, oh, this might be a little inappropriate. I was like, I was kind of liking it.
Oh, gosh. Well, patients don't seem to care. So whatever
No,
works.
I think they actually feel comfortable when they know we're human.
Yes. That's one thing that I think I have to remind people, even with this podcast. It's like when I put my bolo on today, I wanted people to remember that we are actually people, and
we're normal human beings.
Yes, so
that just know a little bit too much about a gland in the neck.
Yes, exactly. Can we actually
going back to that? Wait, okay. I have one more story because you know me. You're usually the one that does this, but I have another story. So somebody sent me. It was either on the Lube Tube Instagram or my personal Instagram, a video that's going around about awkward songs while you're at the gynecology office. And because, like you'll be sitting there and we have music playing in the rooms, right? And we're really trying, I think, in our office to try to find a station that really fits a gynecology visit.
We're struggling.
And I'm just going to say, the other day, I was doing a pelvic exam on this lady. And John Mayer, Your Body is a Wonderland, is playing in the back. And I don't know. I don't think it's the right station.
I mean, like we're just trying to hype up our women in there. So
I mean, I love it, but maybe we should ask the patient what they want to be hearing while they're getting a pelvic exam. I don't know. Maybe Your Body is a Wonderland is not it.
I don't know. I often hear what we're playing, and I'm just perplexed on how it got to that, but whatever makes people comfortable. So
great.
Okay, let me get back on track. Okay, Jeanette.
Okay, sorry.
That's okay. So I want to bring things together, and how can the thyroid affect our menstrual cycle? How can it affect fertility? Things like that.
Mm-hmm. So it can make them heavy, irregular, or just completely absent periods, right? It can completely take your period away if it's hyperthyroid. It can sometimes take it away if it's hypothyroid, right? So if you're having irregular periods and you're not on birth control, thyroid is one of the things that needs to be checked, right? Also there's, like you mentioned earlier, the connection between thyroid symptoms and perimenopause, menopause symptoms. Is a lot of the things that we mentioned earlier also can mimic the signs of perimenopause. So that's why you mentioned getting the full panel drawn, not just checking the thyroid, but also checking the hormones, right? Or not just checking the hormones, but also checking the thyroid, because they can go hand in hand. And then the also important thing is fertility concerns, right? So if your thyroid is messed up and it's not working appropriately, a lot of times women will actually have issues with becoming pregnant and their fertility. So that is actually a big workup that we do when you come to see me and you've been trying to conceive and it's just not occurring and it's not happening, or maybe even a fertility specialist, REI, right? Those also can also check all of that too. So that's a big deal, right? If the thyroid's not working appropriately and you're not getting pregnant, a lot of times medication has to be added in order to try to get that to work appropriately. So you do start to ovulate or even keep a pregnancy. Mm-hmm. Mm-hmm. The other thing that I thought is important is that after, or even when you get pregnant, the thyroid can actually change, right, while you're pregnant. And those hormones also get thrown off a little bit while we're pregnant. And so a lot of times with our pre-OB or our OB panel that we do when we first find out you're pregnant, we check a thyroid there because maybe you've never had thyroid issues before, but now that you're pregnant, the thyroid could be thrown off. So that is something that we actually check on your blood work when you come to see us in your initial pregnancy visit. Yeah. It's crazy how much little things can affect this small little gland in your neck, and it can basically cause a whole lot of symptoms.
Absolutely.
The last thing I think that we should talk about is kind of if a patient doesn't want to do medication, right? So say they don't want to take thyroid medication. I have a lot of patients that don't want to take anything. And what they can do to kind of help with maybe Hashimoto's or hypofunctioning thyroid. There's a lot of diet things out there, but the most important one that I have found that actually works is gluten-free diet. Okay. So if you're in a state of inflammation, lowering that gluten intake can be really, really helpful at trying to basically lower that inflammation in the body, which then helps not so much inflammation going towards the thyroid. And I don't know about you, but I've never tried a gluten-free anyways. I actually eat a gluten-full diet. Probably not a good thing. But gluten-free is hard to do.
I back in the day, I was dating somebody who had to be gluten-free. Mm-hmm. And this was like probably 15 years ago. And there was nothing. Like we had to really try to make it a true gluten-free diet. But now it's pretty easy to be gluten-free. I shouldn't say easy, but there's lots of options now. Right. So I encourage people, if that's something that you want to try, don't be scared because there's certainly a lot of options now.
Sure. And that's great that restaurants are now kind of jumping on that. And then also just grocery stores too. They have a whole lot of options there too.
Yeah. But PSA, just because you're gluten-free doesn't mean that you are incredibly healthy or making like healthier choices. I mean, gluten-free is literally taking the gluten out. There's still other factors involved.
Sure. Yeah. Fats and calories and cholesterol and all the things there that we got to consider. And sugars, right?
Everything you can find in a gluten-full diet. Right, Jeanette?
It's so good.
Okay, keep going. Sorry.
We went to that place that you and I went and had lunch at that one time, or dinner. I guess we went to dinner in Green yesterday. That chicken place that we went to,
yes.
the Birdhouse. That restaurant is so good. And it's got the cutest little house. Mm-hmm. Yes. Yeah. There's this restaurant in this area right outside of New Braunfels called in Green, this little town in Green. And if you're not from this area, you might not know what Green is, but it's this cute little town full of shops and little bars and little restaurants. And there's this little, it used to be this little tea room, but now it's been bought by a company or by a little family-owned business called the Birdhouse. And it's all chicken. And their food is so good, and it's probably full of gluten, but it is so good. Anyways, I got that salad that I had last time, that fancy salad, because it makes me feel a little bit better about eating fried chicken. But it was so good.
Yeah, no, that place is really good.
Okay. Anyways, I thought I would do a little shout out to them. It's delicious. Because I'm sure that the Birdhouse is listening to the Lube Tube.
I mean, duh.
All right. So I think just kind of closing up, kind of basically pulling it all together and just talking about the importance of getting the full thyroid panel done and then going over all your thyroid labs and figuring out if this is an issue or if it's not an issue or if it's something else, right? And then really talking to your provider about different medication options or supplemental options that you could take to get your thyroid working at its most appropriate level. Those are all important things. And then once you do, and if you do get started on a medication, key point is follow-up, right? Because these medications have to be adjusted. It's not going to be like a one dose treats all, especially in the NP thyroid. Those only come in 30 milligram increments. So we're talking 30, 60, 90. And then where you've got your levothyroxine, that is a bunch of different dosings, right? And those are all over the board, right? They're not in exact increment changes. So where you might feel really great for a long time on the same dose, if you start having basically your symptoms coming back, then we need to get your labs checked to make sure that I don't need to adjust that dose a little bit, whether you're on levothyroxine, the Synthroid, or you're on the Cytomel, or you're on NP or Armour Thyroid. So these are things that we need to follow up. I would say every 6 months to get repeat labs just to make sure.
Definitely. And also, I know we talked a lot about, or just a second ago, about diet, but managing stress is also important and getting good sleep. I mean, those are obvious things, but just to further support what we've said a million times.
Right. And I think a lot of people don't understand what happens when we sleep, right? Once we get to that REM sleep, it's where our body repairs, right? And if we're not ever reaching that stage of sleep, that REM sleep, then our body's never really getting all the way repaired for what it's going to have to go through the next day or what it's just done for us that day. So sleep is so important. And if you're not sleeping well, then you need to talk to your provider about, does this need to be treated with supplements, medications, hormones? I do think sleep is huge, and I am glad you brought that up.
Or do I need to stop drinking alcohol?
Oh, yeah.
Right.
I'm just going to say, obviously, I told you we went to Green yesterday. I only had one glass of wine.
Oh my God,
right?
look at you. Wow.
Thank you. But I've been finding that the more I drink more than one glass of wine, I feel freaking terrible.
I'm sorry.
Perimenopause is such a bitch.
It is, but maybe it's a good thing. Maybe.
No, it's a good thing. It's a great thing for my liver. My liver is probably so happy, right? But the fun part of me is like, man, I used to enjoy a couple of glasses of wine listening to live music in Green. But one glass, I'm like, okay, I'm good because I don't want to sleep. If I have to make that decision, do I want to sleep or do I want to drink wine?
Hard decision.
Okay. Yeah, absolutely.
Okay, before we go, let's take it to our segment.
Oh, you're going to sing it this time?
No. I did it last time.
No, come on.
No.
Slippery Solutions with
B
and J.
Okay, we just got one, but I think this will be a helpful one.
Okay.
Dear B and J, I have an embarrassing question. For as long as I can remember, I have suffered from chronic BV. Nothing seems to work to eliminate it. It's exhausting, and I just want something to make it go away. I'm a clean person, I swear. Help?
Yeah. 100%. There's no doubt that you're not clean. This is just a really pesky bacteria that can overgrow in our vaginal tissue. And there's different types of BV. A lot of people think that BV is one bacteria, but there's actually a bunch of bacteria that can be called BV, right? But the most common one is something called Gardnerella. And Gardnerella is a lot of times easily treated with an antibiotic called metronidazole or Flagyl. And this can be done either vaginally with a gel that you do for 5 nights or an oral pill that you take twice a day for 7 days. But guess what? Just like every other bacteria, there's something called antibiotic resistance, right? And with antibiotic resistance, it might be that you have been doing this same antibiotic, either the Metrogel or the Flagyl orally, and you're resistant to that antibiotic. And so you think you're treating it all, but it's really not getting rid of everything, and then it's regrowing. So you might want to have the conversation with your provider to see if you could try a different antibiotic. There is actually a really good new one on the market. It's called Zasiato. It's a one-time gel that you place in the vagina.
Zasiato.
It's Zasiato.
That sounds like a dance.
Maybe it's a salsa. Yeah, this one is actually a different antibiotic. It's actually clindamycin. And you might just need a different antibiotic. But there is a really good thing that you can do over the counter. And there's a product line that we've talked about before with this podcast, and it's called Bonafide. And they make a probiotic, and it's called Claire V. And you can take that probiotic and you take it daily for 15 days. And just for 15 days for 6 months consecutively. And there's over an 80% reduction in the recurrence of BV or yeast. So Claire V is one of my favorite things. If you decide you need this, reach out to us and we can get you a 25% off coupon code. But that's one of my favorite products that I have for patients that have recurrent BV. So what I normally do is treat them different than they've been treated in the past. And then I put them on Claire V as soon as they finish their course of antibiotics. And I do that for 6 months. And if they return and they're having other symptoms, then I actually do something called a full spectrum panel where I actually check a little bit more than just the BV and make sure that there's nothing else causing that. And I think we talked about that with our vaginosis episode, and that's that ureaplasma that we talked about.
Nice.
That's it. That's what I got.
No, good answer. I think the hardest part with people with BV that's chronic is getting them to understand that they are clean and that it's not,
no.
something that they're doing wrong. It's just, we got some flora issues. So
Yeah. And I feel sorry for these girls because they're so embarrassed to talk about it during the exam, or they're embarrassed for me to do the exam. And I just try to make them feel as comfortable as possible and be like, hey, look, this is a normal thing. And you are not the only one that's coming to me complaining of this, and we can fix it.
Absolutely.
Yay. Great episode.
Great episode. I love your bolo. Happy rodeo week.
I love yours too. I actually love the story behind yours because I love antiques and I love grandmas.
Thank you. Me too. It's really, it's nice when you have little things that have little stories behind it.
Agreed.
Yeah. All righty. Well, until next time.
Till next time. Thanks for listening, guys.
Talk to you soon.
Bye. The information provided in this podcast is for general informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition. There is no provider-patient relationship formed. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. The hosts, guests, and producers of the podcast do not assume any liability for the application of the information discussed. Reliance on any information provided by this podcast is solely at your own risk.